Thank you for coming. Welcome. This is the Building Brain Awareness talk series. The nature of this talk series is to get into information that is important for brain injury, and we have all different kinds of talks. Today is something very interesting and something that I don't know anything about, so I'm really excited to see what Dr. Jerrod Brown has to present on brain injury and a neurocriminology and forensic neuroscience perspective. Jerrod has done a number of talks here before. Thank you very much for doing this talk, and why don't you just take it away? And if anyone has questions, you can raise your hand, or you can. Jerrod always makes rooms for questions. Also, you can put your questions in the chat, and we'll get to them. So,
Thanks, Stan, for having me back. Hope all of you are doing well. Thanks for tuning in live today. So, my name's Jerrod. Here's my email address. Reach out anytime if you have questions. I give lots of talks on different dimensions of traumatic brain injury. And today we're going to take a deep dive into why I do believe it's really, really important to understand neurocriminology and forensic neuroscience, especially if you're working with folks who are involved in the justice arena, who have a history of suspected or confirmed traumatic brain injury. Just in case you haven't heard me present before, here is a copy of my bio. I have a PhD. I got 6 master's degrees. I have many graduate certificates. One of my graduate certificates is in traumatic brain injury. I've done a lot of writing on brain injuries, consulting with different organizations, including legal providers, on the forensic legal criminal justice side of this. I go on a lot of podcasts around the world talking about various topics. So if you're looking for any resources, just shoot me an email. I can definitely send you a whole bunch of stuff. Our agenda is pretty straightforward. Our part 1 today, I'm just going to introduce you to neurocriminology briefly and forensic neuroscience. Part 2, how does this relate to the clinical side of things? So we'll talk a little bit about medical and mental health. Part 3, heavy duty discussions on how this relates to the criminal justice, legal forensic arenas. Part 4, how do we take this information, apply it to your interview, your intake, your assessment, your screening process? And then part 5, strategies, solutions, interventions. Please type in the chat box, as Dan said, if you have any questions. Come off mic if you have any questions, anything you want to add. If I'm saying anything you just flat out disagree with, let's talk about it. So neurocriminology, I've been doing a lot of work in this area the last few years. I've developed a couple certificate programs, a micro credential. I've written a lot of articles on this now, going on more and more podcasts. And I just really think if the criminal justice and the forensic arena moved in this direction, it would give them more of a holistic understanding of why some people engage in problematic, aggressive, antisocial criminal behavior. So one of the reasons why I really like neurocriminology is because of this here. It's multidisciplinary informed. One of my master's degrees is in criminal justice. One of my master's degrees is in clinical neuroscience. Another master's degree is in applied clinical nutrition. I have a couple more as well. The reason why I took those is because it's really multidisciplinary informed. And when you're studying complex human behavior, it's pretty clear that there are a multitude of prenatal and postnatal neurobiopsychosocial and genetic factors that may be at play. Obviously, today we're talking about traumatic brain injuries. We'll talk about the frontal lobe, executive dysfunction, metacognition, but I am going to weave in some of these other things as well. So as you can see here, neurocriminology is guided and informed by all kinds of fields, including nutrition, physiology, biochemistry, neuroscience, and criminology. If you go into the weeds with the neurocriminology research literature, basically in a nutshell, here's what it says. If you become neurocriminology informed, you're going to be in a better position to understand the neurobiological roots of criminal behavior, including what happens in utero. As someone that studies neurocriminology, I really believe crime prevention starts in utero. So enhancing pregnancy outcomes plays a role in reducing future criminality. I'm convinced on that. I have plenty of research to back up why I say that as well. You'd be in a better position to understand irrational behavior, human behavioral dysregulation. So self-regulation, inhibition, impulse control problems. If you work with folks with really serious mental health challenges, people with drug and alcohol problems, behavioral addictions, I do believe neurocriminology can also provide you with some added insights and resources that can help you develop even a more effective intervention plan. Neurocriminology has implications for all kinds of things, including the development of a neurobiological informed intervention. People are surprised to hear this, but nutrition plays a huge role in combating criminality. There's tons of studies that support that, addressing food insecurity, malnutrition, and the list goes on. So part of this we're going to talk about today, if you're working with a justice involved individual who has a history of traumatic brain injury, we need to take into account some of these other factors: gut health, sleep health, circadian rhythm, what the person eats, their inflammatory markers. The list goes on. We'll talk about all this today. In the neurocriminology literature, it does talk about brain injury, not just traumatic brain injury, but it talks about other forms of head trauma as well. But there's empirical based articles that do talk about in this literature base. If you work with justice involved populations who have brain injuries, which you probably do because half of folks in prison or jail or more may have an undiagnosed brain injury, becoming neurocriminology informed, I think, can add so much value to the good work you're already doing. Neurocriminology also has implications for moral reasoning. This research talks a lot about when you work with somebody, maybe they have psychopathy, maybe they're diagnosed with antisocial personality disorder, maybe you work with a client who has empathy deficits, or they just have a lot of rule following problems. It helps peel back the layers and put together the pieces of the puzzle that better explain what's going on in their brain and body that may be contributing to that. Forensic neuroscience, I think, is a very close brother or sister to the field of neurocriminology. I've been given more talks on this. I'm actually in the early stages of developing a very comprehensive micro-credential program for a group on the national level on forensic neuroscience. So basically, in a nutshell, forensic neuroscience is just taking neuroscience and applying it to crime, applying it to the law, applying it to the criminal justice system. This research literature also talks about the importance of understanding neurobiological factors that may play a role in aggressive behavior, self-control deficits, morality, social decision-making. The list goes on.
What does the word forensic actually mean or add? It sounds so legal, so like those crime shows.
Forensic science is like a big umbrella term. Under that umbrella, you could have all kinds of dimensions of forensics. You could have forensic criminality. You could have forensic botany, forensic phylogeny, forensic DNA analysis. Forensic neuroscience is taking brain-based science and applying it to the law. So when you think of forensic, think of how it applies to the law, criminal behavior, probation, the courts. Forensic psychologist. I'm not a forensic psychologist. I teach a lot of forensic psychology classes. I'm a professor, trainer, researcher, and consultant, but I have a lot of friends that are licensed forensic psychologists, and they may do forensic evaluations for the court, competency to stand trial evaluations. The work that a forensic professional does is all over the map. Maybe you have somebody that's a forensic social worker, or a forensic case manager, or a forensic therapist, all kinds of different avenues to take. Forensic neuroscience can be applied to any one of those fields because if you work with human beings, if you understand neuroscience, what happens? Well, we better understand the brain, how people learn, neuroplasticity, the frontal lobes, the amygdala, and the list goes on and on and on and on. But forensic neuroscience basically is crime-related neuroscience, studying antisocial behavior, psychopathy, how this applies not only to the criminal justice field, but also what about civil litigation, tort cases? There's some interesting stuff on that as well. If you're a legal professional listening to this, you work in the courts, you probably also want to learn about neurolaw, as basically taking neuroscience and applying it directly to the legal system. I'll stop briefly after each section just to let everyone soak this in, open it up. Any thoughts we have? Dan, anybody typed in the chat box?
Dr. Brown, what coming from me is like lots of these determinations of criminality are external. And so I'm going to be listening for where your research includes the internal experience of the brain injured individual.
Okay. Thank you, Nancy. Yeah, see what you think as we get deeper in the weeds here. And if it didn't cover that, I'll stick around as long as we need at the end. So I think we all know what a brain injury is. There's various dimensions, mild, moderate, severe, mild, kind of used interchangeably with a concussion. Some literature says it's a little different, but I pretty much use it interchangeably with a concussion, but it's multifaceted. It's life-changing for a lot of people. It's a silent epidemic because the majority of people who have sustained a brain injury, they've never gone to the doctor or they've never been diagnosed. And it's especially common when we're talking about criminal justice involved matters, domestic violence, child abuse, things of that nature, which are very, very high among perpetrators and survivors of those population groups. So again, severity level, mild, moderate, severe. I would say most of the consultation work that I've done with legal cases involving somebody that has a brain injury has been the mild to moderate. In my experience, and I could be wrong on this, but just what I have seen, the folks that have a really severe traumatic brain injury might have significant disabilities where maybe they're in a group home or maybe they're around loved ones or family members 24/7. I hate to say it, that's almost a protective factor in a way against committing a crime, which I'm not trying to come off callous or anything like that, but it's the folks that have the mild to moderate, at least the research says, that might be more likely to end up in the prison systems, in the jails, in the forensic state hospitals in our country. And again, anybody has any differing views or opinions on that, please weigh in. The causes for brain injuries, as we know, are all over the map. And we'll talk about some of the main causes in a minute. The clinical outcomes can vary. Why can one person with a brain injury seem to recover quite well, but that some other person had that same type of brain injury, but then had way more severe deficits? Well, there's a lot of factors to take into account. What happened before the brain injury, what happened during the brain injury, and what happened after the brain injury is a factor. We're all impacted by a brain injury. I'm sure all of us know somebody, a friend, a family member, a loved one, a coworker who's had a brain injury. So we're all impacted by this. It impacts all socioeconomic groups, gender, all of that. So this is very, very common. The statistics, and I hate to throw out numbers, I've gone through thousands of TBI studies probably over the last 15 years now. And I've seen statistics anywhere from there's 2 million brain injuries in the US every year up to 10 million. Who knows what the right answer is? But what I can tell you, if you're working in the criminal justice system, drug and alcohol treatment programs, homeless outreach settings, domestic violence shelters, gang prevention programs, you're working with folks with brain injuries all the time. These are some of the most common causes for a brain injury that you will find in the literature. Obviously, this is not an all-encompassing list by no stretch of the imagination, but if any of you are evaluators, you're working in this field, you're a clinician, it's probably not a bad idea to get into the habit to ask clients during your intake Oh, have you had any falls in your life? How many car accidents have you had? Tell me about your history of playing sports. These things start opening up the door to maybe this person did get hit in the head. Have you ever slipped and fallen on the ice? Have you ever fallen off a bike? There's a multitude of factors to take into account. So mild traumatic brain injury and acute post-concussion symptoms, I pretty much use interchangeably. Here's what the research says in a nutshell. Headaches are going to be more common. Fatigue. I know Dan and I in early talks are doing a talk next year on traumatic brain injury and fatigue. That's a very complicated topic that we opened the door to last week when I gave the talk. Memory issues are very, very common, and the list goes on. But again, everybody's different. Not everybody with a mild head injury is going to have all these things going on. So every person's different. And part of it is, did they seek recovery right away? Did they get plenty of rest? Do they have good support? What's their family network like? Did they get good sleep? Have they had multiple mild traumatic brain injuries in their lifetime? That's a whole nother can of worms. If you look at the research literature and you go deep in the weeds with it, here's what it says in terms of typical symptoms that are common among all forms of traumatic brain injury. You're going to have some level of cognitive-based impairment, so you're probably going to have more executive function problems. We're going to talk about that. Headaches. Tendinitis is very common. Again, not everybody with a brain injury is going to have tendinitis, but it does come up more frequently. And the fatigue, again, I want to really just hone in on that. That's a big clinical issue and forensic issue. Why is it a forensic issue? Think about this. Let's pretend the person with a brain injury is being interviewed by law enforcement. Law enforcement doesn't know the person has a brain injury. The client is exhausted. There's good forensic literature out there that indicates that chronic sleep deprivation may be a factor in some cases of false confessions and inappropriate waiver of Miranda rights as well. And I've consulted on cases where those things have come up. So when we're thinking brain injury, traumatic brain injury, it is very, very important to understand neuroscience because obviously a brain injury it's all neuroscience. I mean, when we're talking the brain, neuroscience. So there's so much going on in the world of neuroscience. I can't keep up with it. You would have to spend every day, all day long, reading articles just to keep up on the research coming out. But what I can say is when we're talking traumatic brain injury and criminality, the frontal lobes are probably not working at optimal levels. And we'll talk about the frontal lobes quite a bit today. When the frontal lobes are working properly, this is what happens. Every person is different, of course, but the frontal lobes, when they're working properly, it plays a role in language and communication. It plays a role in how we function in the social arena. It plays a role with morality and ethics and decision making, self-awareness, and the list goes on. So now on the flip side of this, if somebody's dealing with frontal lobe impairment, they may have deficits in a lot of these areas. Comorbidities are very, very common as well. So what I want to say is, once we get to the criminal justice arena, I'll reiterate this. By no means am I saying if someone has a brain injury, that equals they're going to commit a crime. But a lot of people who commit crimes have a brain injury in their history. But it's not just the brain injury. We need to be aware of comorbidities. According to research, these are some of the most common comorbidities associated with a traumatic brain injury. Chronic pain issues, very common. Sleep issues, very common. I've done 2 talks for Dan several months ago, one in sleep issues in general and one in circadian rhythm misalignment. Both are very common among folks with a brain injury. Tons and tons of research on headaches and migraine. What about neuroendocrine dysfunction? Why do you want to care about that? Well, if you are working with a client that's dealing with endocrine dysfunction, their hormones are off. And if their hormones are off, that's our body's Wi-Fi. That impacts everything in the human body. behavioral changes. This is a factor for some instances of criminal justice involvement. And I've seen this in many cases I've consulted on. Somebody had a brain injury. After the brain injury, their behavior, their personality legitimately changed. This is a factor in some cases of relationship conflict, divorce, parenting capabilities, very sad situations that I've known about where this issue came up. So the research says anywhere between 25 to 88% of people with a brain injury may have some behavioral changes, and it's more severe when we're talking about more profound types of brain injuries. If you dig into the literature on behavioral and personality changes, what does it say? Well, in some cases, a person may have more aggressive behavior. Prior to the brain injury, maybe they were really chill and relaxed and just go with the flow. I've heard cases after somebody had a brain injury, maybe they're more irritable, they're more moody, they're more aggressive. In some cases, they may be more paranoid. They may come off as very flat and indifferent or apathetic. If that person's in a relationship, they have coworkers, and nobody's ever been educated about a brain injury. Nobody knows what the heck's going on here. They probably will run into some relationship conflicts. This is another driver. If somebody with a brain injury does become involved in the justice arena, is social behavioral kinds of challenges. In some cases, after the brain injury, the person might have more risk-taking behavior, which places them and others at greater risk. And what is a big risk factor for a future brain injury? The research says having a previous brain injury. Because if that previous brain injury goes unaddressed, unmanaged, untreated, that person now may be more impulsive, which places them at harm's way to sustain another brain injury on top of that. So why do we want to become brain injury informed, regardless of what field we're in? Well, research says, unfortunately, risk of suicidal thinking does go up. When we're talking brain injury, I'm not saying everybody with a brain injury is having thoughts of suicide, but the rates of suicidal thinking, if we believe what the research says, definitely goes up. Rates of self-injurious behavior goes up. Rates of vulnerability and victimization. I've given a lot of talks on the topic of brain injury and domestic violence. If you Google my name and type in traumatic brain injury strangulation, you can find an article I wrote on that on the national level that highlights the importance of, if you're working with survivors of crime, it's so important to become traumatic brain injury informed. And if any of you are working in the arena of risk assessment, anger management, violence prevention programs, a very high percentage of your clients probably have a history of head trauma, the research says. Dan, I'll park the brakes if we have any thoughts before we get into this next section.
I have a lot of thoughts. Anyone have any questions or comments? There's a lot of layers and complexity to brain injury. Two thoughts I want to share is one with the behavioral changes. So, for anyone who may or may not know, I do a podcast where I record with brain injured people. The goal is to discuss the nature of what their internal experiences are, aka their invisible problems. And I think for everyone, there's a behavioral change, but what is underlying it is always or often the brain injury problems, and then that gets interwoven with the misunderstanding and the frustration of trying to do things, trying to function, trying to be basically not sitting in your room in the dark alone. And it's very, very daunting because of the brain injury problems, and that leads to behavioral changes. So I think sometimes people will have a clear change due to impulsivity or due to something that you could say that that's a clear change in their neurobiology or how their brain works. But other times it's a behavior that's in response to the brain injury problems plus what is happening. And I have many examples of this. I don't want to get into all of them, but I think that word behavior, I think, is loaded with brain injury for me at least. And the other thing is with suicide, I think almost every person I've talked to, suicide has come up in several shapes or forms because of all the problems, plus the misunderstanding, plus the aggression and aggravation. So there are some comments of the interwovenness, anosognosia, a lack of awareness of the problems also came up in the comments, and that's a huge driving factor because it's like you're going on with your life and you're not aware of what has changed, but yet problems are happening, and the outside world is also not aware. So that's a it's just super interwoven, and yeah, I just wanted to comment on that because it's a common factor across brain injury. So thanks for mentioning that, and I think every brain injury is different, but these are common features that people end up in.
Dan, thank you. I always learn so much from you with this as well. So thank you. And anybody else has thoughts, comments, anything, we're all here to learn from each other as well. So definitely type in, come off mic. So this next section, forensic, legal, criminal justice. So I'm going to show you a ton of statistics because I do think it's important for us to be aware of this. So rates of brain injuries within jails and prisons and forensic state hospitals are astronomically higher than the general population. There were a couple studies done, I think it was in the 80s or early 90s, involving inmates on death row. There are two studies and very small sample sizes. And both studies found that 100% of the participants in these studies who were on death row had a brain injury. So if we believe what that research says, everybody on death row probably has a history of head trauma amongst a million other not so good things. Here's another just statistic. If we take a look at this, there are some studies, and it depends on the confinement setting, maybe as high as 85% of incarcerated adults may have a brain injury. Most of these cases, they've never been diagnosed. We got any probation or parole officers, folks working with people coming out of jails and prisons? Probably half your clients have an undiagnosed brain injury. The research also says when we're talking about female offender populations, if you work with females who've been incarcerated, the rates are even higher because a lot of females who've been incarcerated have also been the survivors of domestic violence. And a lot of times that domestic violence resulted in that person sustaining a brain injury. Looking at it a different way, the rates of brain injuries among offender populations is 3 to 8 times higher than the general population. So it's not just the brain injury that is contributing to this. So let's say maybe you're working with somebody, they've been convicted of a very violent crime, and you find out they have a brain injury. What are some of the other layers we want to consider? I can't stress how important it is for all of you to learn about sensation seeking. This is kind of a personality type, kind of partially rooted in executive dysfunction, but this is going to be somebody that has a lot of thrill seeking behaviors. It's very common among people with drug and alcohol problems. When we study criminality, another variable is to really understand early childhood trauma and prenatal trauma and fractured attachment patterns. And then also, is the person dealing with a co-occurring drug and alcohol problem? These are 3 variables you want to consider. It's not the only variables. Here's another variable. So a lot of times, let's say somebody with a brain injury does get into trouble with the law. It's usually not in all cases, but it's usually rooted in more impulse control problems where the person didn't set out to maybe commit a crime, but it was really in the heat of the moment. They weren't thinking through their actions. So poor impulse control has been linked with temper control problems, decision making and judgment issues, being more impatient, and high levels of irritability. What I will say about irritability, and I've given talks on this before, irritability may be a gateway into full-blown rage. So if you can target irritability, screen for it, and treat irritability, that would be highly recommended in terms of preventing future impulse, criminality, anger control problems. So back to the frontal lobe. So you're working with somebody who has a brain injury, they committed a violent crime, probably, I can never say 100%, but probably the frontal lobes are not working properly. What does it say about the frontal lobes and violent behavior? Well, inhibition is part of executive function. That is our brain's parking brake. When we have good inhibition, our parking brake is on, we can pause, we can reflect, we can be more patient. When we have disinhibition, when our parking brake is not working properly, what happens? We're more impulsive, we have more anger, we're more irritable. That is a huge driver here. Emotional dysregulation is going to be more common. Self-correcting issues. So this can relate to somebody, maybe he's in court-ordered treatment. And a lot of times court-ordered treatment doesn't work that well. Let's just be honest if you look at the literature. Because a lot of those treatment programs are a one-size-fits-all approach for all clients. We need to individualize our approaches, because if somebody with frontal lobe impairment, brain injury, goes to a court-ordered treatment program, and that court-ordered treatment program isn't taking these things into account, that client's probably not going to be too successful sitting in a group, listening to a lecture, dialoguing with other people, taking notes simultaneously, managing time, organizing their thoughts. It's overwhelming.
How do you treat that? How do you treat the irritability? How do you work? Like, if it's not one size fits all, and I agree 100%, add impulse control to a person's abilities.
Well, when we get to the last section today, that's all on tips, strategy, solutions. I'll give you hundreds of ideas to think about.
Great, thank you.
Can you give attention to root cause? Because irritability isn't a cause, it's downstream of root cause. And you know that. The research tends not to speak about it, so that's why I'm highlighting it.
When we get to the screening section, I'll point out a lot of different things that we might want to consider through a holistic lens that could be driving the bus with irritability. Because you're right, I like irritability is the leaf of the problem. What's the core? Well, it could be fear, it could be confusion, it could be sensory overload, it could be blood sugar dysregulation, it could be malnutrition. There's a million reasons for irritability.
Right, and a million reasons all at the same time. And they're not just possibilities. And sometimes the interview of the human and their experience is the missing link.
Yeah, and here's 10 more things that could cause irritability on this slide. Noise exposure. We know sensory overload is very common. Extreme temperatures is a factor. Air pollution. There's a lot of literature coming out now on air pollution and problematic behavior. Alcohol withdrawal, alcohol intoxication, living in a very crowded housing environment. All of these things may be a driver or a combination or none of these, but I'm just going to point out several things to think about. If any of you work in the juvenile justice arena and you work with children and adolescents who have full-blown conduct disorder, research says routine screening for brain injuries would be highly recommended, because adolescents who have conduct disorder, there's a good chance that a lot of them are going to have a brain injury on top of fractured attachment patterns, on top of an elevated adverse childhood experience score, and probably elevated levels of prenatal trauma as well. When we look at this through a juvenile justice lens, if any of you are working with juvenile populations, a couple things you want to be aware of. Rates of brain injuries are more common. Experiences of trauma, abuse, neglect, parental loss, severe economic disadvantage. So we need to take into account poverty, homelessness, marginalization, oppression, food insecurity, and the list goes on. It gets very, very complicated. If any of you are working directly in the courts and you're a lawyer or doing work with lawyers, the very nature of somebody having a brain injury and who is a defendant in a criminal case, navigating that trial process can be very challenging and overwhelming to that individual. One of the variables, again, this is one piece of the puzzle, poor comprehension of legal language. This comes up all the time. It is very important for attorneys to make sure when they're communicating with their client who has a suspected or confirmed brain injury to really be aware of what language they're using, because legal jargon is very complicated and someone with a brain injury, and many people aren't going to understand what it means to take an oath or a plea agreement or a competency evaluate, all that. You need to really explain it in simple terms. There's some literature, not a ton. When we're thinking about brain injury, if it is somebody being interviewed by law enforcement, they may be at greater risk in some cases to have trouble understanding their Miranda rights. And a couple of the variables to consider is impaired comprehension of what those Miranda rights even mean, poor processing speed, which basically means when that law enforcement officer is interviewing that suspect, that law enforcement officer, again, is going to have no clue that suspect has a brain injury, and they may be talking in a rapid fire manner. And people with a brain injury, a lot of times, have slow processing speed, so they can't take in a lot of words at the same time. And the very nature of being interviewed by law enforcement is scary and confusing and overwhelming. And in some cases, it may be done late in the evening and now the person's sleep deprived too. All of these factors can get in the way of that person understanding their Miranda rights. Here's something to think about, but we don't probably think about enough. What happens if it is a witness who has a brain injury? So there is a little literature on, okay, the person didn't commit a crime, but they're the eyewitness to a crime. It does get a little challenging in some cases, depending on the brain injury and lineup identification. What the literature says, there's not a lot of literature out there. The person who's an eyewitness who has a brain injury, do they have facial recognition deficits? Do they have any memory issues? Do they deal with information processing problems, confusion? These are things that I suspect the attorney who's representing the other individual may call into question the validity of that eyewitness's testimony, when in fact, many people with a brain injury can give really solid eyewitness accounts, but there are some people with a brain injury that may struggle as well. So this is where an expert comes into play, and it gets very complicated, obviously. So someone's been sentenced, gone to jail or prison, they've served their time, and now they're getting released back in the community. A lot of times, unfortunately, and I've seen this firsthand many, many times, if the brain injury's never been identified, and then probation and parole and halfway houses and case managers who work with these folks getting out of jail and prison don't have a clue about brain injury, a lot of times these people are not successful on probation. Think of this in general. Take a look at this. This is the challenges that most folks leaving a jail and prison face: finding housing, staying sober, transportation, medical insurance. Look at all these things that people getting out of jail and prison have to deal with in a lot of cases. Now you add a brain injury to the mix. Now we can see why it can be very overwhelming. So it's so important for people who work with folks on probation and parole, outpatient treatment programs, halfway houses, to also become traumatic brain injury informed. So I've done a lot of work in the area of domestic violence, family violence, intimate partner violence. The research says that a very high percentage of perpetrators and survivors of intimate partner violence have a history of traumatic brain injury. It is very, very common. So any of you working with these populations, you are working with folks with brain injuries, probably undiagnosed all the time. Any of you working in anger management programs, a call to action, become TBI informed. By no means am I saying all your clients in your anger management program have a brain injury, but there are probably a lot that do. By no means am I saying if you have a brain injury, you're going to become a sex offender or you're going to commit an inappropriate sexual behavior. But there's plenty of research that does show a lot of people who commit an inappropriate sex behavior, crime, whatever you want to call it, may have frontal lobe impairment, may have had a history of brain injury. I have done a lot of work in this area and consulted on many, many cases. So it is another piece of the puzzle to consider. If you look at the traumatic brain injury literature within the context of inappropriate sexual behavior, what does it say? Perseveration could be a piece of the puzzle. Lacking the understanding of personal boundaries. So these abstract reasoning deficits is a huge topic to consider. Basically what that is people having a hard time understanding how and why questions, planning for the future, seeing the forest through the trees, executive dysfunction. We got to be aware of the topic of confabulation. This is where it gets tricky. Confabulation is false memory creation. This is probably the topic that I get emailed about the very most out of all the topics I specialize in. Tons of research shows that a lot of people with brain injuries do confabulate. Let's say, here's where it could play out, where it gets really tricky. The person's been convicted of a sex crime. They have a brain injury. They've served their time. They're court ordered to sex offender treatment. They have a proneness to confabulation and suggestibility. They're sitting in that group sex offender treatment program. And if somebody's prone to confabulate, they may hear all of these stories from other people in that group when people check in. That person with the brain injury who's prone to confabulate may hear all these stories. Those stories may get embedded into their own memory, and now they believe that they actually did what this other person did because their brain is not processing the information correctly. And if you encode inaccurate information into your memory and then report it as true, that's a false memory. That's confabulation. Huge factor to consider with criminal recidivism. So somebody gets out of jail, prison, and then they reviolate, they get rearrested. Plenty of research shows, learn about TBI. It could be a factor in some cases. So in a nutshell, this is what some of the forensic criminal justice literature says about traumatic brain injury. Why do we want to care about this? Well, if we don't take it into account, it may contribute to more treatment issues. It may place that person at earlier engagement in the criminal justice system, especially if that brain injury has never been treated or addressed. If the person has a brain injury and is sentenced to jail or prison, they might have more adjustment issues within that context, which could result in more in custody infractions. And the list goes on.
The Gordian knot, which comes first, criminality or the brain injury? What do you?
Somebody's asking if
Yeah.
what comes first?
Yeah, again, I guess it. Yes, that's the question.
Well, if I put on my neurocriminology hat, let's take a really deep dive into that question. I would first start with prenatal experiences. What happened during pregnancy? Was that pregnancy free from chemicals, drugs, alcohol, abuse, malnutrition? If you want to get really complicated, there could be some genetic factors. There's intergenerational transmissions of criminal behavior. There's literature out there on that. Genetics could be a factor. And then when the child's born, was there any birth complications? Was there any early childhood trauma, fractured attachment patterns? What was the relationship like with caregivers? Was there an undiagnosed learning disability? Are there self-esteem issues? Did the person drop out of school early? These are just a few of the variables you'd want to consider with that question. That question is not a simple yes or no. There are so many moving parts with that. Could the brain injury contributed to their criminality in and of itself? I think the short answer is yes in some cases, especially if you knew that person and they were law abiding, but then they had a really bad brain injury. And then all of a sudden after that, now they're getting into trouble. They're reckless in their behavior. They got rage control issues. That could be a factor. But maybe on top of that, are they sleep deprived? What are they eating? What's their support system like? Are they dealing with depression? The list goes on. So criminality is complex. And my goal today is getting us to really think holistically and really starting to look at the pieces of the puzzle and stay curious when you work with folks who engage in really concerning behavior.
Yeah, I think that that's a very so thank you for answering that question, and also thanks for asking the question, man, Manfred, because I think that I ultimately think that brain injury is a part of the human, like I think brain injuries has happened historically forever, and it changes the way we behave and think, and people don't sometimes consider that, but whether it's a cause or effect, I don't think we can answer that. But each person being different is a huge factor to consider as well. And I can share that I know two brain injured people who are my friends who have really good memories and really good spatial navigation, and I don't have those things, so it's really funny because I'm like, "Are you sure?" And they're always right, and they don't have those problems. And I know a few people with confabulation issues that have over the years like interwoven into their lives, and so each person would be drastically different. And also the frustration and aggravation, especially when your brain injury problems are at their worst. I've made rash decisions, and the fuse, you have no fuse when you're in that state, but when that person is rested and otherwise taken care of enough, that isn't going to present itself. And I also know people with judgment issues, so it's like such a, but with each person you can talk to them and learn what they're dealing with.
Dan, what about this? Maybe the person with the brain injury committed a crime, but because of the impairment, they don't know it's a crime. Maybe they committed the crime out of desperation or fear. Maybe they committed the crime because of high levels of naivete, gullibility, and compliance. And they were talked into doing something because they were scapegoated, and now they overconfessed and they took the blame for the entire group. I've seen cases like this. So a lot of layers here, a lot of things to consider. So how do we take what we're talking about today and apply it to like your intake, your interview, your screening process? Well, I just want to throw the statistic out here. Look at this. Again, who knows that this is across the board? But this study found that as many as 86% of people with a brain injury did not receive therapy targeting their deficit. So a very high percentage of people with brain injuries might not receive the proper services they truly need. Here's where it gets even more complicated. Back to my neurocriminology hat. So these are some biological factors that may play a role in criminality. Hormonal dysfunction. I believe in a lot of cases, again, by no means not all cases, but a lot of times crime starts prenatally. And I'll show you some things. Neurotransmitter dysfunction, what we eat or the lack thereof, air pollution exposure. That is why I truly believe a biopsychosocial approach is so needed. I've given lots of talks on this recently to different groups. The biopsychosocial model is a very holistic approach. It takes into account biological, psychological, and social factors when working with clients. And it really can dig deeper into the weeds with your clients and gather information that can be used to develop a more informed intervention plan. Here's a very practical example. There's way more to the story than this, but this is a very practical example of how you would incorporate the biological aspects of the biopsychosocial model into the good work you're doing. Getting in the habit of asking your clients about medical health conditions. It would probably be important to know if your client had irritable bowel syndrome or diabetes or migraine. You're not diagnosing those things, but those are things that can absolutely impact mood. It would probably be helpful to learn about what your client eats. If they only eat fast food, they skip breakfast every day, they binge eat right before bedtime, all of that's been linked with more problematic behavior. What about their physical activity patterns or the lack thereof, sedentary behaviors, sleep patterns? These are some factors to consider. Another topic where it gets very complicated is the HPA axis. I've given numerous talks on this, and the HPA axis is the hypothalamus, pituitary, adrenal axis. It is the human body's main stress response system. It's a hormone regulator. It has a lot to do with cortisol in the body. I'm sure a lot of you have heard of adrenal fatigue. It's really HPA axis fatigue. And the research says people with brain injuries likely have dysfunction in their HPA axis. And if you look at the neurocriminlogical literature, this may be a biological risk factor for aggression and crime in some cases. What happens if you have a client that is dealing with circadian rhythm misalignment, where you're working with a client who's up all night watching movies and sleeps all day long? They don't get natural sunlight. Check out the episode I did for Dan several months ago on circadian rhythm misalignment and traumatic brain injury. There's not a lot of literature out there on this, but there's some literature now pointing to the fact, could this be another piece of the puzzle? Circadian rhythm misalignment throws off our hormones, impacts our mood, impacts our gut microbiome, and it could trickle down into leading to aggressive behavior. Lots of people with a brain injury may be dealing with circadian rhythm misalignment for a variety of reasons, not just poor lifestyle factors, but the very nature of sustaining a brain injury could have damaged parts of their brain that are related to these things on this slide. So I've worked on cases where people have circadian rhythm misalignment because of just poor lifestyle choices. This is not poor lifestyle choices. This may be a direct result of the brain injury, which gets even more complicated. So it's really, really important to work with a sleep specialist to really try to get a handle on these things. What about hypoglycemia? One of the most important and underappreciated topics in all of criminality, I think. It's hardly talked about. There's so much research to support this. So basically what this means is if your blood sugar levels get too low, you're dealing with hypoglycemia. It doesn't always have to do with diabetes. You can have low blood sugar levels, and we all have this happen. Have you ever skipped breakfast and lunch rolls around? You're a little more irritable, you're a little more moody, you're a little more impatient. That's hypoglycemia in a nutshell. What happens if you have a client who only eats junk food all the time? They're they're drinking their energy drinks, eating tons of candy, donuts, fast food. They're spiking their blood sugar levels, and then it crashes. That may be a factor to consider with violent behavior and aggressive behavior. It throws off their glucose metabolism. What is the fuel for our brain? Glucose. If our glucose gets too low, hypoglycemia. If we don't have enough glucose in our brain, we're more moody, we're more irritable, and it's a recipe for self-control deficits. What happens if you have a client that drinks a lot of sugar sweetened beverages? plenty of research shows that these drinks are a threat to human health. They're the devil in disguise. I have no problem saying that. They taste good, they look good, they're terrible for your brain and body. It may be a risk factor in some instances of problematic behavior. Why do you want to care about food insecurity? Well, the overwhelming majority of people coming out of jail and prison would meet the definition for being food insecure. Research says between 70 to 91% of people coming out of jail and prison are dealing with food insecurity. Why are the rates of food insecurity so high among criminal justice involved populations? Social stigma, unemployment, homelessness, lack of health insurance, housing instability, social isolation, histories of parental incarceration. This is not a diagnostic tool. These are just questions I've kind of collected over the years because of the work I've done on this topic. If you have a client that has any one of these things going on, it may be they're dealing with food insecurity. Dig deeper. If you work with folks on probation, not just folks in jails and prisons, this is what the research says. Trauma is very common, sleep issues, executive dysfunction, fatigue, blood sugar imbalances, and traumatic brain injury. It's so important for probation and parole officers to also learn about these topics. We don't have time to get in the weeds in this. This is not an all-encompassing list, but here are 11 TBI-based screening tools you can find in the research literature. I'm not endorsing any of these, but what I can tell you, some are more complicated than others. The helps tool, you can find that online. You can do that with a client in 2 to 3 minutes. Some of these have been used in justice involved studies. If you work with clients with these issues, by no means it doesn't mean they have a brain injury, but it's a red flag indicator that should encourage you to dig deeper, because the more we can screen for this, the more we can identify people with a brain injury, get them properly assessed, properly treated, it's going to make a world of difference. If you work with somebody who has a lot of aggression, anger, violent behaviors, and they have a brain injury, here's where it gets complicated. It's not just the brain injury. Here's some of the puzzle pieces. Research says it could be related to information processing deficits, self-regulation issues, problem-solving deficits, fatigue, confusion, co-occurring post-traumatic stress disorder, which is very, very common, especially if we're talking about veteran populations and traumatic brain injury, sensory processing issues, and executive dysfunction. That is why we need a holistic and integrative and multidisciplinary informed approach to dealing with these things. So abstract reasoning, and I'll send my slides to Dan. This is kind of what it is in a nutshell, but a very high percentage of people with a brain injury are dealing with abstract reasoning deficits. If that person is in therapy or treatment and that therapist doesn't have training in this, and they use a lot of insight-based therapeutic approaches, and they ask a lot of how or why questions, that's going to be very tricky for somebody with abstract reasoning deficits. Here's the anosognosia Dan brought up before. I did an episode on this several months ago. A higher number of people with brain injuries may be dealing with anosognosia, which is the lack of awareness that I even have a brain injury. And why do we want to care about anosognosia? Because it can impact the client's self-esteem, their self-worth, their self-concept, and their self-efficacy. Alexithymia. Dan, did we do a talk on that too? I think we did. I can't remember.
We did not, but I have another expert who has done two, and I also deal with this, and so I have a podcast with it. But you and I have not done one. If you want,
Okay,
it's always good to get different views.
no,
But
definitely. I've written a lot of articles on this, done a lot of podcasts with different groups, but the research says 30 to 61% of people with a brain injury are dealing with alexithymia, compared to about 10% of the general population deal with this. Basically, this term means emotional blindness. Sensory impairment, very common, another piece of the puzzle. I think there's a strong empirical based argument. If somebody has a brain injury, they probably do well getting a sensory evaluation, working with an occupational therapist, at least initially. Because if you can get a handle on this, that can play a role in reducing irritability, Nancy, as well. Should I just push through to the end, Dan, and then open it up to questions at the end?
I think so. There's so many points that we think we could talk for a long time and are important. If there's no questions, anyone? Okay.
Tip, strategy, solutions. Well, if you want to tackle the crime problem, it's complicated. So we need a multidisciplinary and holistic approach. And neurocriminology can help with that. Forensic neuroscience can help with that. If we look at holistic health approaches, what does that mean? Well, you're taking into account mind-body approaches, how the brain impacts the body, how the body impacts the brain. We're taking into account physical factors, mental health factors, behavioral, social, spiritual, biological. It's very multidisciplinary informed. Typically, in my experience, when we're working with justice-involved populations who have a brain injury, they probably need to work with a team of professionals who have a variety of expertise. What are some interventions in the neurocriminology literature? Quit smoking. People are surprised to hear that. That's a crime prevention technique. If somebody smokes cigarettes, that may be a risk factor for criminality. I have a certification through the Mayo Clinic on smoking prevention. I have a great appreciation now for the literature on smoking. I didn't realize how not so good smoking is when we're talking about criminality, mental health, nutrition. Work with a nutritionist, a dietitian, change what the person eats. Have the pregnancy free from alcohol, drugs, tobacco products. These are intervention and prevention strategies. What are some other neurocriminological informed intervention options? Well, nutrition interventions, yoga, mind-body interventions, cognitive emotional training, looking at problematic lifestyle habits, mindfulness training, neurofeedback, promoting neuroplasticity, reducing sugar consumption, understanding the gut-brain axis, and supporting digestive health. These are all wonderful things to consider for interventions. In the TBI literature, when we're looking at it through an aggressive lens, there's empirical-based literature that also talks about the importance for using the biopsychosocial approach. If we start looking at interventions that target biopsychosocial factors, well, cognitive training, that can help the brain. Positive social activities, being around positive people, maybe it's a social skills group. Exercise, physical activity interventions. Last week we did a talk, Dan and I, on walking interventions for TBI. What I always stress is talk to your healthcare provider first. This is not medical advice. Work with a dietitian, nutritionist, and then monitoring health risk factors. So working with your healthcare provider, going to the dentist, addressing chronic pain issues, addressing digestive health problems. In December, this will be the entire focus of my talk, but I do believe lifestyle medicine approaches can be a great way to combat problematic behavior. And it's a no-brainer to me. These are the 6 core aspects of lifestyle medicine. It's all common sense, but stress management, exercise, avoiding drugs and alcohol, tobacco products, eating good food, positive social connection, and getting good sleep. The support team for somebody with a brain injury can be long, depending on the individual, but working with speech, language, communication pathologist, neurologist, physical therapist, vocational rehabilitation specialists, peer support workers, mental health providers, coaches. When we're talking about improving the health and well-being of somebody with a brain injury, in the TBI literature, it really does stress the importance of promoting positive health and well-being. And that's why I think lifestyle medicine approaches can be extremely helpful, because this article doesn't say lifestyle medicine, but if you look at what's on this slide, these are all the pillars of lifestyle medicine that is talked about in this TBI article. Other interventions to consider: services. Hopefully, we all know now that a multidisciplinary informed approach is so needed. Case management can play a huge role. Being in some structured programming, working with specialized providers who might have expertise in some of these areas we're talking about today. What are some earlier life factors that we could implement in terms of protective factors? Well, in an ideal world, we would strengthen that individual and their family's resilience. We would promote proper prenatal care. We would promote exercise and reduce sedentary behaviors. We would promote proper nutrition. We would promote avoidance of toxic chemicals when possible. Easier said than done when we're talking about like air pollution, lead exposure, mercury, things of that nature, and doing everything we can to promote healthy and positive family attachment patterns. Here's one article of many that again talks about nutrition is a great and cost-effective way to address crime. Again, it's probably not going to be the only factor involved, but you have many, many studies that show when people eat better, especially in correctional institutions, their problematic behavior goes down. I have a graduate certificate in exercise prescription, and my final project for that program, I did a systematic review of the literature related to exercise within jails and prisons. And tons of research shows get people moving more, exercise in jails and prisons, eat better. It will play a role in reducing future criminality. We all know that exercise is good, but take a look at this one article, and I underline one thing. This particular article found that routine engagement in exercise is a way to address criminal behavior. We all know that exercise is good for mood, energy, sleep. It does get more challenging when we're talking traumatic brain injury. There's a lot of factors to take into account, and a lot of those factors we discussed last week during the walking intervention talk. And this is one slide I showed last week in that walking talk, but there's plenty of research that shows get folks out with a brain injury moving more in terms of walking. Obviously, we want to make sure that they're cleared by their doctor and there's no safety concerns. Here's what the research says in a nutshell about physical activity interventions if you use within jails and prisons. Again, lots of good stuff, basically. Good for the brain, good for the body, good for mental health. Lots of things going on here. I do believe it's very important to also focus on skills development when we're working with justice-involved individuals who have a brain injury. So a lot of times that person would do well working with a case manager, a skills worker, a coach, and teaching skills in these areas to help improve functioning in some of these practical life skill areas here. Other helpful approaches that I think are good for all of us. We want to individualize the approach because every person with a brain injury has different experiences, different strengths. We want to use a non-judgmental lens. We want to be aware of attachment patterns, self-esteem dynamics. You want to create a very calm atmosphere because maybe the person's dealing with sensory issues, trauma histories. You want to be empathetic, use motivational interviewing. You want to instill hope. you want to encourage, you want to motivate, you want to empower. These are all great for anybody. And Dan, that's all I got for us. That was a lot of content in a very short amount of time. There's way more to the story with neurocriminology than this, but hopefully it gives us a starting point. Here's my email, folks. Reach out anytime. And Dan, I will stick around for thoughts and comments.
Thanks for sticking around, and thank you, Jerrod, and other people are saying thank you as well. Some of the questions that came up in the chat, what you had said, Jerrod, is the exact opposite of the current penal structure in terms of the support. I know that in general there's not the right approaches for brain injury. So how can that be promoted, or how can that be improved?
I've been doing tons of trainings for tons of justice involved groups, developing micro credentials. I'm trying to get the word out that we need a holistic approach. We need a multidisciplinary approach. We would do well learning the basics of this. I'm not asking anyone to be an expert in the gut microbiome or inflammation or circadian rhythms, but if you at least know the basics and you're starting to screen for those things and you understand food insecurity, you're in a better position to understand at-risk people. You can refer out to other providers, you form partnerships, you don't get siloed in. I don't feel like I know hardly anything. So if you have a mindset of curiosity and always wanting to learn, I think that's good because I've done enough trainings for enough groups now. Some groups, especially a lot of criminal justice folks, they don't want to hear other ideas, perspectives. They got it figured out. Their way is the highway. I don't think that's the best approach.
Yeah.
Individualize our approach. Every person you meet is different. A one size fits all approach does not work. The research is very, very clear on this. And I'd mean no disrespect if we have criminal justice professionals in here. But if you look at the rates of people who leave jail and prison, who go back to jail and prison a few years after release, that system does not work that well.
Excellent presentation as always. But yes, I think I put a question in there, and that, I've been trying to advocate on behalf of TBI for almost 3 decades now. And what you said here should be shared with many different organizations, all that. And I still think that's a weakness in what professionals are trying to do here vis-a-vis what's really the message getting out. And unfortunately, the message is still not getting out how complex TBI is and how we need to have, as you had in one of your slides, partnerships, especially like you just indicated in the penal system, sheriffs, we need to have the law enforcement folks, even some of the clinicians. I just recently had the experience. I serve on the hospital review board for the state of Minnesota now, and the last case that we reviewed was clearly someone who had a TBI, but the clinical and the treatment people and the direct care people had no clue that this person could possibly have a TBI. So I think that education and that part is really still one of the struggles that we have in the system. And I thank you for your assistance and what you do in the different settings that you do, these podcasts and everything else, for trying to get the word out.
Man, Fred, I appreciate you. So good to hear your voice. Been too long. And I am so appreciative of all the great work you've been doing over the past many decades in this field.
Thank you both. Yeah.
Thank you.
I'm only a few years into this, trying to get the information out. But yeah, it's super complicated. And I just want to add, so some of the interviews I've done with brain injury people, like with Nancy, she said people need to be curious. Another person, Julie, I don't know if she's here, she said people need to give us the benefit of the doubt. And this was my experience too. And I'll go higher up with this challenge. The biopsychosocial model, I don't think addresses brain injury because there's the biology of the brain, but there isn't information on how, when this part gets injured, damaged, made harder to use, it then affects your mind, your internal self in a way that is underneath psychology. My brain injury is fully was like underneath the psychology stuff. So I think brain injury is still in the cracks, and it's such a bad problem that it's like people can't imagine what we're talking about when you have the brain injury issues, and then they supplant, well, you should just be able to do this, or you just be able, people work very hard to manage their aggression and behavior and all this and that, and somehow it gets just loaded, and they don't listen to what we're saying, and it drives me crazy, and it keeps happening over and over and over. I see this with it's so common. So I think we're all on the same page. I don't know how to deal with that aside from getting this info out and trying to get people to believe us. Anyone else?
Hopefully I showed you guys numerous interventions to consider that probably aren't considered that often. So just think about this. What would happen? Someone with a brain injury involved in the justice system had the right accommodations, was exercising, eating healthy, getting good sleep, you're supporting gut health. How does that relate to crime prevention? Well, their brains work better, their bodies work better, their hormones are better, their blood sugar levels are better. They can interact with other people more effectively. And it's not just a brain injury. If the entire justice system did this, it'd be huge. And I don't want to open up too many cans of worms, but the research does say you go to jail or prison, a lot of times those folks come out more metabolically unhealthy. They are more likely to put on weight in there, more joint pain, more digestive health issues. There's a lot of reasons for that. And I've given talks on all those topics. So helping the prisons and probation and the courts becoming more health informed is a no-brainer, and it really will save money in the long run, I do believe.
Manfred, please.
Well, and yeah, Jared, and I think that your numbers that you had on recidivism were actually very optimistic. I worked in Michigan when I worked on a Michigan Prisoner Release Initiative, and we did extensive study of releasing 6,000 individuals, 4,500 of which had mental health issues. And the recidivism rate at that point in time that both the Justice Institute out of Philadelphia and we in Michigan found is that it's about 3.5 months, 6 months being a favorable one, but most of the time it's like almost 3.5 to 6 months, so that the recidivism rate is much higher than the public really understands. And unless you have some of the intervention that you're talking about, yeah, it'll continue and it won't help the system in the long run. The other point that I just want to shoot out as an advocate is that we are fighting here, the clinicians are fighting a systemic issue in that sports um, systems don't want to recognize TBI because it doesn't make them money. Same way with what I ran into with the VA and the Pentagon when I tried to advocate on behalf of veterans. They don't want to recognize it either and go more public with it because that does not help them in recruitment. So you've got large system, and it's the same. I'm sorry to be pejorative, but it's kind of the guns and NRA kind of a thing. You've got some large systems that are really not willing to address the problems head on. And I think that's going to be our long-term issue. While we, in the clinical area, it's well recognized and makes sense. There are systems out there that are still fighting against that recognition.
Thank you for mentioning those examples. And I know in my experience, I've been trying to like tap on their doors, and no one wants to talk to me, both in athletics and the military. And I get the same feeling in each case is they don't have any interest to speak. Um, there was a term in the chat. Olivia wrote the brain injury recovery continuum would be so helpful, and I think she was talking about the ways to help people improve over time and across so many factors. And I think that that's a universal for brain injury and missing. I know I'm trying to create it for myself.